Hello, it's Anthony Chadwick from the Webinar Vet, welcoming you to another episode of VETChat. One of my favourite vets in the world is here today, Rachel Dean. I think if we had to ask one question of Rachel, who is an expert, now I can't even use that word because I think she will get upset with me, evidence-based medicine. I'm just going to say, curiosity-wise, why?
Why what?
Well, just curiosity, isn't it? That's the whole thing about evidence-based medicine. We have to be curious. I'll just tell a little story. When I was growing up, people used to avoid me as a child because they would tell me something and I'd say why, and then they'd say, well, because of this, and then I'd say, well, why? And in the end, they said, just go. Well, my mum used to say, because why is a crooked letter,
Yeah.
and you can't straighten it. I think when she got sick of me, and I
Yeah.
never quite understood the answer, but it usually did stop me in my tracks for a little bit. But I think as vets, if we're fundamentalists who know the answers to everything, but we're not prepared to maybe ask why, it makes the career probably less exciting, doesn't it?
Yeah. I think we don't know everything. I think that is, as well as curiosity, it's one of the cruxes of evidence-based veterinary medicine, is that it points out what we do and what we don't know. And when you become an evidence-based practitioner, you live in that place of uncertainty. So it opens the door to be able to ask why. When I got the role to found and direct the Centre for Evidence-Based Veterinary Medicine at the University of Nottingham at the vet school there, one of my mates who happened to work in the pharmaceutical industry, so had suffered with my whys for quite some years, he phoned me up and said, this is perfect for you because you've always asked why do we do that, why are the rules like that, why are the guidelines like that? Because if someone doesn't have a solid answer, you need to think, well, why should I do that with my patient then? Because if you're an evidence-based practitioner, you're patient-centered. Yes, you have to understand the evidence. You need to understand your own expertise, and the context and values of the client or owner or organization that sits around that animal. But one of our jobs when we think in an evidence-based way is definitely to remain curious, but also skeptical of some of the things we're asked to do, but focus on our patient to make sure that we do good and don't do harm.
And I think it's also about, I'm going to sound old now, but youngsters of today, in your impression or opinion, are they doing too many tests and things? This is something that's thrown out, isn't it? Are we sometimes? When I qualified, so I'm going to say they probably said the same thing about me 30 years ago. We come out as empiricists. Somehow we're not really sure what we're doing, so we often would just try treatments rather than take that history, do that good clinical examination, think about the most common things it can be. Common things are common. There is a tendency, when you first come out, to think everything's complicated and it's going to be a really rare disease, and therefore we have to do loads of tests before we engage our brain.
Yeah. And I think I qualified 30 years ago, so the world was very different. But I don't necessarily think it's an age thing about doing all the tests. I think it is an approach to clinical decision making. So
Yeah.
I think what we're seeing more and more fear-based or defensive medicine. So you do a lot of tests or a lot of treatments just in case, because if you didn't do them, you might get in trouble. I'm not really sure with who, but we're fearful of underdoing it and not being good enough for ourselves, for our peers, for the profession. But I think that it's not necessarily age or the year you graduated that drives the type of decision making you've got, because everyone has a different approach to risk. They have a different moral compass. They worry about lots of different things. But we certainly do way more tests, if we're just going there for a bit, than we used to. When I qualified, yes, we had in-house analyzers, but they weren't very good and they didn't look at very much. Whereas now we've got lots of in-house diagnostic testing, lots of stuff that we can send various different tissues and samples away to the lab, and lots of different imaging techniques as well. We did have an ultrasound scan in my first job, but it was from the bum of cows. I did put it on dogs' abdomens just to see, because I was curious and wondered whether I could actually do something useful with it. So we have a lot more choice, which is wonderful for the development of our profession and animal health, because we can do much more than we used to be able to do. But the majority of patients we see don't need those things. And so I think there's lots of different ways and patterns that people make decisions, but when you approach diagnostic testing from an evidence-based perspective, it's always good to think, why am I doing this test? What am I trying to find out, or what am I trying to improve, or what I'm trying to check? Sometimes we're monitoring, aren't we? But then also, how good is this test at helping me with the answer?
Yeah.
So we have tests that can tell us about sensitivity and specificity, but that's all about the test. That's not telling us how it will help us move forward with this patient in front of us right now. That's called the diagnostic utility of a test. And actually, diagnostic utility is all about, if you do this test, will it change the care pathway of the animal? Will it mean you go, oh, I don't have to do anything, or oh, I need to treat, or oh, I need to refer? So if we do tests without thinking why, let's go back to curious evidence-based medicine, then we will start to create some problems for ourselves, because what happens is, if you do tests indiscriminately, just by the law of statistics, if we do 20 tests, one of them will be wrong.
Yeah.
And we don't know whether it will be wrong. So it should have been abnormal, but it's normal, or it should have been high and now it's low, or the other way around. So if you're not careful, that will start taking you somewhere that's nothing to do with the patient. So I think it's quite a complex thing, but it's quite an interesting concept in evidence-based medicine.
It was really interesting, Rachel. I'm suffering for the first time in my life with sciatica, and I wouldn't wish this on anybody. But I went to the doctors because after 3 weeks of physio and paracetamol and ibuprofen, it wasn't hitting the
Yeah.
spot. So they put me on cocodamol. And one of my friends is about a year ago diagnosed with prostate cancer, and he was saying to me, you really must get tested, etc., etc. Now, you may or may not know, but I think the PSA test is not terribly reliable.
Yeah.
And actually, I got a form from them, and they said very much this point. What are the pros of doing the test? And I think maybe 10 years ago, that would have been what the leaflet was about. But
Yes.
there was also, what are the cons of the test? And the cons of the test are, you get a high result, and actually, it's not meaningful. It's not because you've got cancer, or you could even get a low result and it could miss it. So as you say, there's that diagnostic predictability of a test. And if it isn't that good, then, should we be using it?
Yeah, and there's loads of things in that. I hope your body is doing well, and I hope your back gets better.
Hmm.
Um,
Well, that's very kind. Thank you.
without, in a way that, for both of you, is good for your quality of life and means you don't enter a world where you're overtreated or overdiagnosed. Because
Yeah.
when we're doing tests, we're normally doing them either to diagnose a disease or screen for something. And actually, the way a test performs will be different in a healthy population compared to an unhealthy population. So
Yeah.
I've just turned 50. So I've had my first breast screen, quite painful, but it's a good thing to do when you're over 50, because it's more useful than if I'd had it doing, started doing it when I was 45. And PSA screening has changed over the years. I'm no expert at all, but what was happening and why. So we used to do more PSA screening in men than we do now, and it's because screening tests aren't always good. They can always be bad. Like your
Yeah.
leaflet that you got, that's awesome. I'd love to be able to do that for veterinary diagnostic tests. And I think we forget that. We often think more is good. That makes me a good vet. I'm more superhero if I've done lots of stuff. Whereas actually, if you do a test that isn't very useful for the thing that you're trying to diagnose or screen for, you can do harm, because you do what we call overdiagnosis. You start to diagnose a disease that's not there, which causes all kinds of worry. Some of the worst case scenarios that happened in humanoids was that people were overtreated. Either women were
Yeah.
investigated for lumps in breasts that actually weren't anything,
Yeah.
weren't ever going to be anything.
Men have prostatic biopsies that they don't need,
Yeah,
etc.
hugely invasive and carry risk. But maybe some of the tests that we do, it's less obvious what the harm is. But if we spend budget on tests we don't need, we're using it up when we could do it something else. It has an environmental cost. We have to puncture the skin and jugular of an animal to get the blood.
Yeah.
And then if we do a whole load of tests, we then have our pain of going, oh gosh, I wish I hadn't done all of this. I've now got lots of asterisks that I think are fine. And now I've got to explain all that to the owner and get a very careful conversation that you don't worry the owner.
Exactly. And then if you have done all those tests and suddenly you need treatment, and say you're on an insurance policy that the money
Yeah.
has almost run out, which often happened to me as a dermatologist, they would come to me having almost spent all their money and not really made any progress.
Yeah. And that can quite easily happen if you don't take a moment to take stock and think about what I would call the healthcare pathway. Sometimes, particularly because of the time pressures that we have in practice, it's sometimes easy to just keep going rather than think,
Yeah,
well, I wonder if there's something I could do a bit differently here. Or chat to a mate, a colleague. The more we do that, we more understand that each of us don't all do the same thing, and there are choices for patients. And unless we talk about choice with our clients, they don't understand that it's there. So sometimes being evidence based is taking a step back and not just being curious about your own practice, but someone else's as well.
I think it's reflecting as well, isn't it? I think it's a controversial area. The Royal College have asked us to reflect on our CPD,
Yeah,
with the form, with the One CPD app. But actually, I think I've never had a problem because I think we all reflect on cases, don't we? When a case goes well, great. But
yeah,
often the ones that don't go so well, you do go back and you reflect, should I have done this differently? That's all reflection, and that all
yeah.
builds on your knowledge for the future, doesn't it?
It does. And I was on a table with a lovely new graduate yesterday who loves his team because they spend their whole time finding out what's going on. And he's really supported in his first job, which was lovely. So he doesn't find that reflective piece challenging. And so I think it is something we all do. Maybe writing it down helps some people, but it doesn't help everyone because we're all different. But I think I work a lot in quality improvement as well. I think we need to be really careful that we don't just talk about the stuff that went wrong, but also talk about the stuff that goes really right or what
Yeah.
appears to be mundane. We should, challenge our everyday practice. I've done a lot of research around primary care and the key clinical questions that people have in first opinion practice. And they're all pretty similar. We've got a lot of similar queries together. And if we don't stop and ask, we think everyone else knows and it's just us that doesn't. Or, when something's gone really well, if we don't tell anyone else, no one else will ever know that and feel brave. Because I think if we just talk about error and stuff that goes wrong and just reflect on that, that would drive fear based medicine.
I think the lovely case of that was, and I don't know if you remember and how you treat them, but oral hematomas. And Judith Joyce wrote a lovely paper in the JSAT, probably in the late 80s, early 90s, using a Penrose drain.
Yeah.
And she'd done a larger number of these cases, and the majority of them had done very well. And of course, it was a procedure that you could do in 5 or 10 minutes. I don't know if you remember sort of cutting the little
Yeah, I
elliptical
do.
hole and then getting all the buttons from all the coats that your buttons had fallen off, and then doing the button thing and
Yeah.
stitching through. And I mean, the dog's ear always looked a mess
Yeah.
post-operatively as well. And by doing this, and it didn't work with every case, but it
Yeah.
worked with a large majority of cases. And this was a dermatologist lady just being curious and looking for something different, wasn't she?
And looking for simple solutions because it doesn't always have to be difficult. And what you said there is that it doesn't work in every case. Nothing does.
Yeah.
So one of my pet peeves at the moment is we're thrown a lot of information as clinicians. And as soon as someone tells you something is perfect or it's got the word gold in the advert, that should raise your curious,
Yeah.
skeptical, evidence based brain because no test is 100% sensitive and specific. No treatment. I read something recently that said a treatment could improve something by 97%. I'm like, we're over that now.
Hmm.
We've made a massive difference to our itchy dogs, to our cats in congestive heart failure. We've kind of done the 80%. What we're tweaking around with new drugs and tests is the 20%. So
Hmm.
we've done a big improvement. We've done amazing work in veterinary medicine, but nothing is perfect and nothing is 100% safe and efficacious. If people tell you that a drug is the safest option, I'd go, really? Show me the data. Because we're not very good at, just like we've talked about the harm of diagnostic testing, we're not great necessarily at looking at the harms of drugs. We've got pharmacovigilance data, but that's not really very good evidence for safety. But everything that has an effect will have an adverse, and every test that has increased sensitivity needs to have a decreased specificity because the two are
Yeah.
equivocal.
Yeah.
There is no perfect one way. And I think sometimes experience, age, greyness in all kinds of ways teaches us that, but evidence based medicine will get you there sooner. that idea that I don't know, we don't know, and there are options. I think it might help us, help me when I started to learn this, to help measure my expectation of how well something's going to go. When I'm teaching students, it helps me with
Mm.
them, but also with my clients. That rather than being so certain about everything,
Yes.
you can talk about the options and go what you're certain and uncertain about, but you sort of start on that journey properly with the teaching a student or working with a client, a little bit more realistic, maybe.
There's a framework, isn't there, though, of how to approach a case. I
Yeah,
think if we approach a case in a certain way, we're more likely to get to a good result at the end, or a diagnosis,
yeah,
and potentially treatment or not. And then also recognizing, as you learn more, as you were saying before, that actually there are so many grey areas. But do you think that maybe vets will look and say, our lives are busy and complicated enough, and now you're asking us to, even think more and more. For example, my big passion, as you know, is the environment, and I will look back now, and I used to, when I had my own practice, I was one of the first to do a VIP plan, and I would say to clients, you've got a couple of kids in the house. The chances of blindness through Toxocara canis is infinitesimally small, but nevertheless, if it's your child that gets blind,
yeah,
you would feel obviously terribly bad about that. I would, because I hadn't worked your dog. This is the kind of fear-based reactive medicine. So I would give Drontal tablets. And even as an environmentalist, not necessarily thinking, well, what is the environmental risks of doing that, and how do they outweigh? So this is, I think, where we're now very much more challenged around sort of preventative medicine, like ectoparasiticides, wormers. Martin Whitehead's done a lot of work. You
yes.
can worm it. You can do a fecal test, and the eggs aren't there. So why would you want to, then give a worming tablet? And obviously, we know that younger dogs are more prone to shedding worms than older dogs. So where would you come at all those sort of situations where the risk is really quite small? We don't have many children who get blindness or sight problems because of Toxocara, and then the effect of potentially all these drugs going into the environment.
So a few things jump to mind there. First of all, the world and science moves on. So
Yeah,
if we're still doing the same thing in 30 years' time that we're doing today, we've missed a trick as a scientifically led
yeah,
profession. And so science moves on, but so does society and context. And people talk a lot about contextualized care at the moment. The context of our clients has changed. We have changed. When I say we, I mean the veterinary professions. But the role of veterinary nurses is massively changed since I first graduated, thank goodness. So the change is inevitable. So what we need to do is not flagellate ourselves for previously doing things wrong or doing things wrong at the moment, but critically looking at what we're doing, why we're doing it, as always, and think about that. But also then, again, from an evidence-based perspective, but also from contextualized care, is don't assume your colleagues' feelings or your clients' feelings. We need to understand their context by asking them. So some people have a very zero tolerance of risk of a problem with their children. Other people, they have, obviously everyone, hopefully most people worry about their children's health, but then they'll also worry about the planet health, the balance of that, and
yeah.
also their budget. So it is complex, and sort of, yes, we're time poor, but the more solid the decisions we make, the easier life actually becomes. But also, if we take that pressure off ourselves that we're supposed to have the perfect answer, because there isn't one, there isn't one, sorry, there
Yeah.
isn't one most of the time, then actually our life gets easier because it enables us to go, well, we've had a chat, I've looked at your animal, today we've decided this, but that doesn't mean we're going to do this forever. We might change where we go again when we have the next conversation. And it might be that a new bit of evidence come to the fore, or my experience has changed because I've done something with another animal, or the client's context changes or their circumstance and values. So there is this idea that we're not in this static place now. So the parasiticide discussion is really interesting, and I've been in some really interesting discussions around that. But it's a very difficult risk-benefit discussion because we're trying to encompass human health, planet health, and animal health. Now, what I see we need to be careful with is that we don't do reactive medicine. So we change one thing because we've got one little bit of the jigsaw, we've got one bit, and we let the rest of the dominoes tumble over, or then we try and make every other bit of the jigsaw fit round it, but it's just one bit. So it is a complex issue, this idea of the environment, these chemicals, animal health, human health, and there's many evidence gaps. And so it's a primary. So, but what I do see is some very opinionated people from all the different areas, and what we need to do is find comfort in our uncertainty, work out where the most important gaps are, and start to improve the evidence base there, but also watch us change. By the time we're talking about changing the way we use parasiticides, we probably already are. And the market has changed. You know, how people buy parasiticides has changed.
Well, it was interesting. You and I were at a
Yeah,
company event, and I was fascinated, and I don't know why and what's been the drivers of this, but actually, and there's probably several drivers which we could discuss, but actually, the market has moved away from topical based products
looks like it.
to
Yeah,
oral ones.
yeah.
Um, and there's a number of reasons for that. And we're not, it's hard to say that an oral product is necessarily better than a topical one, but we know enough evidence around topical that there
Yeah,
is a little bit of a reluctance to continue using them, in the same way if it's a dog that's
yeah.
in a lake all the time.
There seems to be, but if you actually look at the evidence base, we still love to go from A to B to F to G. And so I think evidence-based medicine sometimes make you look a bit boringly cautious.
Yeah,
But what we have to understand is every decision we make ends up in an action, and that action will have an effect if it's a good action. I mean, the last thing we want to be doing is making decisions and having action that makes no difference. That is when we're over treating and over diagnosing. Virtually everyone I speak to in our professions don't want to do harm, but
yeah,
it will happen, and that doesn't mean it's bad. Again, it's just that yin and the yang of something that is possibly good for one thing might have a negative converse effect on something
yeah.
else, and that's okay. But to suggest blanket change in an industry when our evidence base is incomplete needs to be done with care. So if we're gonna change, that's when we need to think about auditing our change. Because if we think we're doing this great thing to have this effect, we need to measure that A, it's definitely having that positive thing,
Yeah.
but also that it's not having any adverse. It's butter and margarine to me. So when I was little, oh, butter was bad and margarine must be eaten. And now we've flipped the other way. And now actually maybe all of the fats in butter are better for us than what's in margarine.
And sometimes there is a bit of fashion in there as well, isn't there?
There is, yeah, absolutely. And I see a lot of hype in our profession, and hype can harm us. So people get very worried about a thing, and we have to go, well, what's the scientific foundation of this, or why are we worrying about
And I
it?
think this is why, with our Veterinary Green discussion forum, the clue is in the word, the discussion,
Yeah,
bringing people together. We can have we see binary politics all over the world at the moment, whereas actually, if we can get to a point where we can, listen more, understand, seek first to understand than to be understood, was a Stephen Covey 7 Habits, and understanding the person better, then you understand why they think in a certain way.
yeah,
And they almost certainly will have some of the truth, and you will have some of the truth. We're very, we can have this fundamentalist view that we're right and they're
yeah.
wrong, which actually doesn't help the world, does it? That sort of
No, because
attitude.
I think evidence-based medicine is about collegiality. You use the word "why" about 6 times in those 3 sentences, Anthony. It's brilliant. But yeah, understanding where people are coming from and why is all around that context and that moral compass and what your beliefs are. Because as a clinician, our beliefs are based in lots of different things, including our experience, but not just our experience. Evidence-based medicine, I think, enables greater collegiality, but also greater kindness, because you're wanting to find out why
Yeah.
someone thinks that and what that's based on. Some people see evidence-based medicine as being really negative because we do something called critical appraisal, but it's 2 words: you critique and you appraise. You find the good and the bad, the yin and the yang of whatever you're reading, but you can do that with someone's opinion. When I sit in a lecture, sometimes I'll go to canine dermatology. I have no clinical need for that at the moment because I'm interested in the speaker and how they're presenting, but also why they're saying what they say. Reference based medicine is different. If you can reference every single statement, you've probably written a very smart lecture, but I'd probably be able to find 3 or 4 other references that say something different.
Mm.
So what we want to see when people are giving us information is at some point they say, well, I don't really know why I do that, or I don't know where this has come from. And then you start reflecting together. And that's really cool.
But I think also in a lecture, and we can give a really factually correct presentation, but we don't move anybody. Nobody's heart is moved by that. And obviously, when you're speaking, partly speaking is about persuasion as well. And so, and I know we talked about it before. Storytelling is actually
Yeah.
important. So we shouldn't make things so scientific, because actually most people, their first thing is emotion rather than intellect. Most of us make our
Yeah, we're
decisions on
human.
emotion as well, don't we?
Yeah, we do. And you can't remove that. And again, sometimes people, when they think about evidence-based medicine, focus way too much on the evidence. So it's this triad of understanding. So that one part of the triad is the evidence, understanding what we do and don't know, and how good that is. Some of it is then, so we become scientifically founded based. Maybe that's where it comes from. But there's no tyranny of the evidence.
Hmm.
It doesn't, if the evidence says you have to tablet a cat 10 times a day, well, it's kind of, the evidence is kind of irrelevant, isn't it? Because
Yeah,
and I can tablet
nobody's going
most
to do it.
cats, but no one's going to do it. No one's got the life that can do it. Those of us that can tablet a cat 10 times a day normally do 10 different cats. So it's irrelevant. So you must always remember the other two parts of the triad, which is that clinical experience. And sometimes it's yours as a vet or a nurse, but sometimes it's the whole team or that of the client as well, particularly with some of our, if we think about owners of farmers, they're hugely experienced in animal health. Um, but then we've got this third bit, which is that circumstance and value, and I would say context of the animal and the person attached to that animal, that we need to encompass that. So it's all about decision making. It's a very human thing to do, and so it's a collegiate thing to do. But what it also enables you to do is not do the same thing every single time, because that, even though the evidence remains static a lot of the time, the circumstance doesn't.
I know we're keen to continue having these chats, and almost in a philosophical way as well. There's so much
Yeah,
philosophy around there as well.
yeah,
But I don't practice anymore, but I do get a lot of friends, acquaintances. When I meet them, or they have my phone number, and they ring me up and they say, "Oh, something's happened to my dog or cat, and I want to give
yeah,
it." And sometimes it's as mundane as, when do we spay this cat or dog
yeah,
or castrate? And of course, that is an interesting area, because at the moment you would have some people say very early spaying, some people would say later. And I remember a paper, and it always felt to me spaying them, very early on, or castrating early on, was, I didn't feel that was, right. And then of course Chris May's paper came out about neutering. I think it was a Great Dane, and the dog broke its leg because its growth plates hadn't fused, so it was more prone because of that. So again, this is again where you see having these hard bound rules where we say we should castrate or spay at 6 months or 12 months or 18 months, and you're not bringing the individual into the mix, is a mistake, isn't it?
yeah. Um, Autonomy is really important to clinicians, and so rule books don't work. But safety nets, guidance, chatting to each other does work. The neutering debate is really interesting, and what I see a lot of, and I've written about it in the Vet Record relatively recently, is everyone seems to be after a right or a wrong. Okay, so that case report, I haven't read it. Certainly haven't read it recently. Might have read it in the past. A case report is just a story. So it's what happened to that Great Dane. Now, it might have broke its leg anyway, whether it was neutered or not. We don't know, because you can't test cause and effect in that. And a lot of the studies that we do have on neutering are not set up in an epidemiological study design way that means you can
Yeah.
actually test it. But again, it's one of those places where the world is already shifting and moving. But what we cannot say still with the evidence base we have at the moment is that if you neuter at 6 months, that's bad, and if you do it at 12, that's right. There's a lot of theoretical stuff going on around luteinizing hormone and other things, but actually we don't have the data yet. But what the evidence base is as good as it can be at the moment is getting people to question the why, hooray, of why. I'll stick for male dogs for a minute, but why do we neuter male dogs at 6 months? Actually, if you look at our data, We have some quality improvement cycles around neutering to make sure we optimize outcomes, because it's a elective surgery. We want to make sure our animal's pain free, we're not overusing antibiotics, etc. But it enables us to look at the patterns of neutering, and people are already shifting.
Yeah.
So some are still being neutered at 6 months, and I hope that's in the context of that animal, for those clients, or for that clinical team and the way they feel. But we get greater peaks later, but still before the age of 1. You said there's a peak at around 9 to 12 months, and there's another peak at around 18 months. And that's probably the behavioural maturation of some of those bigger dogs that's going
Yeah.
on. So I think people aren't making blanket decisions about something like that anymore. I think they are making more considered decisions, and that's great. And as we start to make these changes, if we can study it and study the effect of those changes, we're doing really well. But often we don't in veterinary medicine. We change, and then 6 months later we'll be berating 6 years later we'll be berating ourselves for what we did before. Whereas actually, again, as a profession, if we become more evidence based, as we make changes, we monitor those changes, and you
We
can do that
review.
through quality improvement, and we review and
Yeah.
reflect and we discuss,
Yeah.
and we go, oh, that went well and that bit didn't, and that's okay.
Rachel, this has been great. It's always good chatting to you.
Likewise.
Thank you so much. Lots of food for thought. Hopefully, people listening have enjoyed it as well. But I really appreciate your time. And yeah, hopefully we will have another chat in the not too distant future.
I'd love that. That would be great. And thank you for having me.
And thanks everyone for listening. And hopefully see you on a podcast or a webinar very soon. Take care. Have a great day.